Good afternoon, everybody. As Brian mentioned, I'm Aaron Johnson, and just wanted to just acknowledge that I don't have any conflicts of interest to report for this presentation. I will mention one product as we go through the presentation, but it's not a product that sponsors me at all. It's just a product that we use as part of our evaluation efforts, and there are several similar products available that you all might consider in your own evaluations or might be using in your own evaluations. As Brian mentioned, I have been involved with SBIRT for a number of years, and I just wanted to quickly give you some background on where I'm coming from in terms of doing evaluation as part of SBIRT training grants. I was a site-level project director for a project called Georgia Basics for about 5 years, which was one of the SBIRT state services grants to the state of Georgia, and then served as the director of evaluation for a couple of training grants that have since ended. Both of those were under the Southeastern Consortium on Substance Abuse Training moniker. One was a residency SBIRT training grant that was funded in 2009, and back then the training grants were 5-year grants. Then we received a 3-year grant to train advanced practice research nursing students in about 8 sites in 3 states that ran from 2012 to 2015. Currently, I am involved with 3 training grants, one of which I am the project director on, which is based here in Augusta, called the Georgia Regents Interprofessional Substance Abuse Training, or GRESAT, and then the director of evaluation on training grants that are based at Johns Hopkins School of Nursing, which is training baccalaureate nurses, and at the University of Georgia. So just wanted to take a quick poll from you all to see who's out there. So if you could respond to this poll by indicating what your role is on SBIRT programs.
Okay, so you should be seeing the poll on your screen now, everybody. So please go ahead and vote now. We're just going to keep it open for a few more seconds. Okay, it's counting our results now, and we're going to look at it together.
All right, so a mix of project evaluators and project managers with just a small number of project directors on the line. So let's move on to the next slide. I think Brian has turned that back over to me. So just wanted to give you an overview of the types of students that we are training in the different locations where I'm currently involved. Here in Augusta, we are training residents, including family medicine, internal medicine, and psychiatry residents, advanced practice nursing students, both family nurse practitioners and psychiatric nurse practitioner students, first and second year medical students, clinical psychology students, both at the master's level and at the postdoc level, and then a couple of allied health professions, including physician assistants and physical therapy students. As I mentioned earlier, Johns Hopkins is training baccalaureate nursing students, and then at the University of Georgia, we're training clinical psychology doctoral students, Masters of Social Work students, both at the University of Georgia and at Georgia State University in Atlanta, and then PharmD students that are based at the University of Georgia. So I think our next polling question is just a similar question for you all to let us know the type of students that you are training in your programs. All right, great. So we have a fairly large number of programs that are training social workers, nurses, then a number who are training medical students and allied health professionals, and just a couple that are training residents and pharmacists and other types of students. So let's, Brian, if you can turn it back over to me, we will move on. Okay, thanks. So just to review the learning objectives, these were sent out to you earlier. Our learning objectives for today are to recognize the value of diverse program data in supporting continuous quality improvement and sustainability for your training programs, to identify some strategies for coordinating data measures to enhance evaluation efforts, to learn to apply diverse evaluation and data coordination strategies to support program evaluation goals, and to learn to examine program data through multiple lenses and across diverse contexts. So the way I wanted to set this up today is just to give you a brief overview of the different types of evaluation data that we're collecting, and to really stress the importance of really evaluating every aspect of an SBIRT training program. And I've sort of broken it into 4 different categories, with a 5th category about linking data across these contexts. But in terms of the types of evaluations that we do, we focus on 4 different types of evaluations, 4 different types of data collections, and then within each of these 4 types, we collect multiple different types of data. So the first group of participants that we collect data from are our site coordinators or our program faculty who are actually doing the training. Then obviously the bulk of our effort is dedicated to evaluating the student training and those being trained themselves. And then we like to also look and measure the proficiency, SBIRT proficiency and implementation within the students that are being trained. And then, of course, one of the requirements of the grant is to do a post-graduation use of SBIRT and to collect data on the extent to which it's being used once our students graduate and move into the field. And then the 5th piece is just coordinating the data and linking it across those four contexts to really get a fuller picture of what's happening within your training program. Brian, let's see, I may be able to close. For some reason, I'm not seeing anybody on the screen anymore. That's okay.
Okay, I still see you.
Okay, maybe it's not a problem. I just can't see anything. I mean, I can see the slides, but not anybody. But that's okay. As long as you can see me, I guess that's all right. So let's move on. Did you take over control? Oh, now
yeah, I just gave it back to you.
That's okay. So I wanted to touch on each of these five different types of data collections and then give you an example of some of the results that we found through our efforts to evaluate these different types of, collect these different types of data. So the first type of data that I mentioned that we collect is we collect data from the site coordinators and the program faculty that are doing the SBIRT training within their respective programs. And one of the things that we do in our training program is we do an annual faculty development workshop, because what we have found is that to really get the attention of the faculty that are going to be training SBIRT in their different programs, we need to get them off campus, because if we schedule a full day training here on campus, they will sort of wander in and out throughout the day, and they'll be on their phones, or they'll be getting paged or having to take calls. And so we actually do a 2-day workshop off campus and change the content up each year based on emerging topics that they may benefit from learning about. And so at the end of that workshop, we do a post-workshop survey where they provide us with feedback on the different strengths and weaknesses of the presentations that they saw during that 2-day workshop, feedback on the quality of the training materials, the extent to which they were satisfied with the location and the meeting space where we held the workshop, and then also take suggestions for future workshop topics. And then we use that information to adjust and improve the training that they receive at the next faculty development workshop. And then in addition to that, the other type of data we collect from them is a post-training form. So after each module that they deliver within their respective programs, we have them complete a training form, and I'm going to show you a shot of that in just a second. But essentially we're collecting data on how the training went, how many students they trained, the format in which the training was delivered, if they did role plays, how much time they spent on role play. And so I think I have a screenshot of that. It may be difficult for you all to see, but this is the type of data that we collect after each module, so that we get a sense of how that training is going and how many people are being trained and what's happening within those trainings. And we use that data in a couple of ways, and I'll talk more about that when we get to the coordinating and linking data. But one of the things that we're able to do is calculate the amount of time or number of contact hours each student has in terms of their SBIRT training. Because we're training across multiple programs, different programs allot different amounts of time to the training, and so we like to be able to track who's getting what and how much. And then we also get some qualitative feedback from them in terms of the level of engagement of the students. Some classes that you'll see, the students are really engaged and really interested and enthusiastic, and other groups of students may seem uninterested and like they really aren't paying attention. So we like to get some qualitative information back from our trainers to know what's happening within those classrooms. And then in terms of student training, the way we set up our evaluation is really a quasi-experimental design. So we enrolled a comparison group that we could then compare to the group that did receive SBIRT training. And I'll show you that research design on the next think it's on the next slide so that you'll see what I'm talking about. And then we deliver pre-training and post-training surveys to the group that is being trained. Obviously, the comparison group would only receive a single survey, not a pre and a post. And these surveys are slightly different depending on whether the students that we're training are actively seeing patients or not. So the residents that we're training and the advanced practice nurses that we're training are actively engaged with seeing patients in clinics in various settings, whereas the medical students and the PA students and the psychology master's students are strictly students and are not at the point yet where they're actively seeing patients. And so we collect data slightly differently depending on whether or not they're engaged with patients on a day-to-day basis. And in terms of the survey content, many of you are probably collecting similar items as we are. We do a little knowledge test and do a pre-post look to see if their knowledge increases over time. We collect data on importance and confidence in addressing patients with alcohol and drug use issues, their attitudes toward working with patients who are alcohol or drug users. And then one of the things that we do that other programs may not be doing is we are interested in some potential correlates with conducting alcohol and drug screening and brief intervention. So we actually ask students about their own personal drinking patterns, and then we also ask about their personal experience with substance use disorders. So we ask whether or not they are in recovery, but then we also ask whether they have a family member that may be in recovery or that has an active substance use disorder, so that we can get a sense of where they're coming from as they are receiving this training on screening and brief intervention. And then this is the research design, evaluation design that I mentioned earlier. So we have an intervention group that receives the training, and then we also enroll a comparison group. And this could be a group of students that may have been in their final semester when the training grant began, and we were not going to have time to provide adequate training to them, and so we enrolled them as a comparison group instead. And so we have an intervention group, a comparison group, and then we have practicing and non-practicing within each of those groups. And then with the trained group gets a pre-test and a post-test, as I mentioned earlier. The comparison group just gets a pre-questionnaire. And then with both groups, we're following them up post-graduation to see if the intervention group is more likely to do alcohol and drug screening and brief intervention than that comparison group. So these are just some of the, I dropped in a couple of result slides here that I thought may be a little different than what some of you are collecting and that you may find interesting. So as I mentioned, we ask in these surveys of our students about their own drinking patterns. And so here we are just comparing our advanced practice nursing students to the residents that we're training. And so this is the percentage of students that report at-risk drinking, in this case binge drinking, within the past year, and then the percentage that report binge drinking within the past month. And what we will, and the other thing you'll notice is that this is females only. So because our advanced practice nursing students are 90+% females, we thought that it really wasn't fair to compare the entire group to each other. So we looked at females only, and what we found was that the residents and the advanced practice nursing students were similar in terms of past year binge drinking, but the advanced practice nursing students were significantly higher in terms of past month binge drinking. And one of the things that we have used this information for is just the reality of the people that we're training, and that they may feel conflicted in terms of doing a brief intervention with their patients when they themselves would theoretically qualify for a brief intervention. And then the other thing that we've been interested in doing with this is, particularly with the residents, since that was originally a 5-year training grant and we were providing the training over multiple years, we were interested in seeing if, as they were exposed to more screening and brief intervention training, whether their own drinking patterns would decline, just based on the information that they were receiving about the dangers of alcohol use. So that's one of the slides that I dropped in. And the other one that I wanted to share with you is the questions that we ask about their own experience with substance use disorders. So what you'll see in this slide is that we have a very small percentage of people who are personally in recovery, or at least a very small percentage who openly admit to being in recovery. But really a pretty significant percentage of our students have some direct personal experience with substance use disorders. So the second column there shows the percentage who report having a family member that is in recovery, and so anywhere from 20 to 25% of them have a family member in recovery. The third column is whether a family member's use has caused problems. Advanced practice nursing students, about almost half of them report that they have a family member whose substance use has caused problems. We have a 0% there for residents because we actually did not ask this question of residents. We added this question once we started with the advanced practice nursing students. And then the fourth column, whether they have a family member that has an active substance use disorder. Again, over a third of the advanced practice nursing students report having a family member with an active substance use disorder. And then the last column is just a cumulative percentage. So is anyone who responded yes to being personally in recovery, having a family member in recovery, or having a family member with an active substance use disorder. It excludes whether they have a family member whose use has caused problems, because we only collected that from one of the two groups. So as you can see, almost a quarter of the residents and close to a half of the advanced practice nursing students report having a direct personal experience in some way with addiction. And then the third component that we try to collect data on is on SBIRT proficiency and implementation. And we do this in 3 or 4 different ways, or have done this in 3 or 4 different ways. We use a brief negotiated interview checklist with 2 of our groups of students. The first-year medical students do a standardized patient who reports with at-risk alcohol use, and we have their preceptors observe their interaction with the standardized patient and complete the brief negotiated interview checklist, and then provide those students with feedback, one-on-one feedback based on the checklist. And then the first-year psychology master's students do a video brief intervention with a classmate, and our site coordinator there watches those videos, completes the brief negotiated interview checklist, writes comments on the checklist, and gives them direct feedback based on the review of their video interventions. And then we, for the first-year medical students and really all of our programs across campus, we have a computer-based simulated patient, which was developed by a company called Cognito. As I mentioned earlier, there are several of these available out there, but the one that we use is developed by Cognito. And it has them walk through a patient who is at-risk alcohol user, and they have to select the correct responses as they interact with that virtual patient. And then at the end, they provide the student, the simulation provides the student with a score. And if they don't achieve a certain score, they have to go back and go through the patient again as a way of improving their brief intervention skills. With our APRN students, we have, since they are in clinics throughout the state, we have required that they complete a minimum of 5 brief interventions with the patients that they are seeing, and I'll show you the form that we use for that in a minute. And one of the things that we ask them to do is to check the various components of the brief intervention that they addressed with each patient. And then with our family medicine residents, in the very first project that we had, that was the residency training grant, we implemented SBIRT in the family medicine residency clinics. There were about 7 of those clinics, and we conducted chart reviews over time to see the extent to which the patients were receiving screening and the extent to which those screen positive patients were receiving brief interventions from the residents. So I just want to show you a couple of those data collection instruments. This is the brief negotiated interview checklist that I mentioned earlier that we do with the medical students and with the psychology students. This is just a screenshot from the simulated patient that we used, the Cognito developed virtual patient. And then this is the form that I mentioned that the advanced practice nursing students are asked to complete as they interact with patients in their respective clinics. And I don't know how easily you can see this, but I would draw your attention down to the bottom of this form where, as I mentioned earlier, we asked them to check off different components of the brief intervention so that we can see which steps they're addressing and which steps they're not addressing. And I think in a slide or two I have some of those results so that you can see what the students report as they're interacting with these patients. Yeah, so this is it. So this is the percentage of the advanced practice nursing students using these different components of the brief interventions with their patients. And so what you can see is the most commonly reported steps in the brief intervention or components of the brief intervention is discussing the consequences of use, discussing safe levels of use. About half the time they report using the readiness to change scale, and then if you look out on the other end of this graph, you'll see the least commonly used components is actually making contact with an addiction specialist or referring to a group or referring to a specialized addiction treatment program. And in some cases, you would expect these percentages to be smaller because not everyone who gets a brief intervention is going to need a referral to treatment. So in some sense, you would expect those to be a little smaller. And then in the middle of the scale, setting a goal does not seem to be something that they utilize very frequently. So we take this information and we use this information to try to tweak the modules that we're using in our SBIRT training, because there are obviously a couple of components that they don't feel are as important or that they don't feel as comfortable doing with the patient, and so we try to place more emphasis on those components in our training in hopes that that they will be more likely to use those, and that later groups will be more likely to use those components than these current groups. And then this is the data from the chart reviews that I mentioned earlier that we did with the residents. So this is chart reviews done over a period of 24 months where the blue line represents the baseline chart review, the red line is 12 months, and then the green line is 24 months. And so what you can see is that in most of the clinics, the patients were already getting asked about alcohol use. That's the blue line. About 89% were already getting asked about their alcohol use, but only about a fourth of those were using a validated screening instrument to ask about alcohol use. And so what you'll see is that over time, the percentage that were receiving a validated screen showed a huge increase to the point that at 24 months, almost 96% of the patients that we reviewed in the chart review showed evidence that they had been screened using a validated screening instrument. And then the result of this is an increase in the percentage of patients that were screening positive. So at baseline, only about 1.5% of the patients in these clinics were screened positive. At 12 and 24 months, that percentage had increased to about 10%. And then we also see a significant increase in the percentage that were getting a brief intervention. So about half of the ones that were screening positive were getting a brief intervention. So there's still clearly room for improvement there in terms of making sure that those who screen positive get a brief intervention, but a significant increase over what was happening prior to our SBIRT implementation in those clinics. And then the fourth piece of data that we work on, and this is where we have our most significant challenge, and we're going to ask you all about your challenges in a few minutes, but we try to collect data post-graduation to see the extent to which they are using SBIRT in practice once they graduate. And so we do this in a couple of ways with a post-graduation survey where we ask information about their current work setting and the population that they're serving, the extent to which there was screening prior to their joining the practice, because we want to know whether their joining the practice has had an impact on the what's going on within that practice, their own personal use, current use of screening, and the frequency with which they do different brief intervention components for alcohol and drug use, similar to what we were asking of the advanced practice nurses in that clinic piece that I showed earlier, and then the typical number of minutes that they spend on a brief intervention, because one of the frequent complaints that we hear from our trainees, particularly residents, is that it's going to take too much time and they just don't have the time to devote to it. And then in addition to that, we have done a few qualitative interviews by tracking down some residents that were employed in the local area and sitting down with them for a 15 to 20-minute qualitative interview to ask them what they were doing and what they took away from their SBIRT training, et cetera. And I think I have a couple of result slides here to share with you. This is actually from the advanced practice nursing post-graduation follow-up, where we asked them which alcohol and drug screening questions they were most often using to screen patients. And what you'll see is that the largest percentage for both alcohol and drugs is the quantity frequency questions. We were training them to use the audit, and somewhat disappointingly, only 5% reported that that's what they were using most often to screen their patients. The single alcohol screening question and the single drug screening question were the second most commonly used, and we trained them on that as well, so we felt a little bit better that they were at least using one of the validated screening tools that we had trained them on. But then somewhat troubling is that there's still about 8% who reported using the cage, 11% reported using the cage to screen for unhealthy alcohol use. And that was something that we clearly explained to them was not best practice, but some of them still are using it. And then this is also a post-graduation results where we asked them what they did in terms of helping patients when that patient was willing to make a change. And what you'll see is that the most commonly reported approach was to refer the patient to a support group or refer the patient to counseling or brief treatment. Much less common was any sort of discussion around medications and referral to formal treatment. So one of the things that we'd certainly like to see more of is that our graduates were reporting that they were more comfortable talking about medications with the patients that they were working with. And then our next polling question is, as I mentioned, our biggest challenge has been the post-graduation follow-up, but we'd love to get some input from you all on what challenges you have experienced when conducting your program's evaluation. So Brian, I think, is going to open the poll, and if you all can just tell us where your challenges are in SBIRT evaluation.
All right, here we go. Oh, by the way, Aaron, if you're still having trouble with your video, try clicking the participants icon in the upper right-hand corner.
Okay.
It might be that that's closed.
Okay. I see
So
it.
folks should see the poll now. And votes are coming in. Thank you, and keep it open for a few questions, or a few seconds, rather. And also, at this time, we'd like to ask if one of our attendees can join in over the phone and maybe talk a little bit about which of these challenges they've been experiencing, and maybe connect that with something they've heard on the webinar so far, or just talk about your personal experience with these challenges. So if you'd like to chime in, use that raise hand icon. You'll see that by your name in the participants list, or send me a chat, and I'll need to know that you want to chime in so we can connect your audio line. So keep the poll open for, we'll go ahead, looks like most folks have answered. Let's go ahead and close the poll now. Look at the results here.
Great. So the largest group here is similar to me in terms of the post-graduation follow-up. That certainly is a big challenge. Then looks like we have a fair number who are having trouble tracking the rates of SBIRT use in the clinic sites, and then a smaller percentage that are having trouble hitting that 80% GPRA follow-up rate, and then just a few that answered the other issues. So great, thanks for sharing. Did we get anyone who wants to talk about one of their challenges?
I don't see anyone so far. Put it out there again. If you'd like to talk about your challenge, we'd love to hear from you, and raise your hand. Or
yeah, particularly if you found a way to overcome that challenge.
Yeah. I'm not seeing any hands at this point, but maybe we can talk about it later in the presentation.
Okay. Yeah, we have some other discussion questions coming up in just a couple of minutes that people may want to chime in on.
All right. Let me give you the ball back here.
Okay, and then the final piece that I mentioned earlier is just coordinating and linking all of those various types of data across the different contexts so that you get a fuller picture of what's going on within your training program. So I'm going to give you show you some of the results of where we've linked data. But one of the things that we were interested in is whether or not there was a relationship between the number of training hours the students received or the modality by which they were trained. So for example, we have some training that happens in person, in class, face-to-face, and then others who are trained via video modules. So we were interested to see whether that made an impact on their proficiency as measured by the virtual simulated patient. So we've done that analysis. Obviously looking at pre and post changes in attitudes and confidence, so linking the data from their baseline to data from either their post-training or their post-graduation, looking at attitudes toward working with people who use alcohol and drugs and their self-reported post-training use of SBIRT, whether or not one's personal alcohol use history has an impact on SBIRT implementation and use, and then whether or not their own personal experiences with substance use disorders or within themselves or with family members impacts the level of importance or their level of confidence in addressing patients' alcohol and drug use, or whether it might impact implementation and the likelihood that they will use SBIRT once they are trained and move out into the clinical setting. So just a couple of slides that I wanted to show you. These are results of our pre and post surveys, baseline and post-training surveys. Many of you probably collect similar data and do similar types of analyses, but one of the things that I thought was interesting about this particular result was if you look at the different types of students. So we have medical residents, advanced practice nursing students, medical students, physician assistants, and then the lightest blue line are the psychology master's students. And what I thought was interesting is if you look at the changes over time, the psychology master's students started out with the lowest level of confidence in terms of being able to determine whether patients are using drugs and advising patients who are using to cut down or quit, but ended up at post-training with almost the highest level of confidence. The residents obviously started out highest and ended highest because they are actively seeing patients and have a lot of experience working with patients, and that tends to build confidence. But I thought it was really a remarkable increase with the psychology master's students from time 1 to time 2. And then the other slide here that I wanted to show you, this is their rating of the importance of using a validated screening instrument to assess alcohol use. And we asked several similar questions. I just picked this one as an example. This is whether or not they reported binge drinking in the past year. So the top line is the group that has no binge drinking episodes in the past year. The bottom line is the group that does report a binge drinking episode in the past year. And so what I wanted to point out to you here is that there are some differences, not huge differences, but definitely some differences in the level of importance that they place on using a validated screening instrument, and we saw similar results across all of these questions. But essentially the group that reported that they had not binge drank in the past year had a significantly higher percentage who responded that this was either very important or extremely important. So we do see some slight differences in attitudes, confidence, importance based on the individual's personal drinking patterns. And then I think I have one more results slide here. This is where we linked the number of hours of training to the results from the simulated patient. And so these are scores. The red dots are people who scored less than 79 on the simulated patient. The yellow dots score between 79 and 86. And then the darkest blue dots up at the top are the students who scored between 93 and 100. And essentially what I wanted to point out here is that the differences aren't huge, but they are statistically significant. The students who received 5 hours of training had slightly higher scores on the simulated patient than the students who received fewer hours of training. And when we did this analysis by modality, whether they were trained face-to-face or by video, there were no differences in terms of their proficiency scores. But it does seem that more hours of training leads to higher scores. There was no significance in terms of the percentage of students who passed on the first time, but those who did pass and had 5 hours of training had passed with higher scores than those students who had fewer hours of training. And then that's all the content that I had for today. I had a few topics that we could potentially discuss, and I think I saw someone raise their hand and say that they would be interested in talking about their experience at, was it Adelphi University that popped up?
Yes, that's right.
This is Jenny Hartman from Adelphi University. Can you hear me okay?
Yes.
Great. Thank you for your presentation. I was just going to respond to your question about where we are in terms of data collection and analysis, and for what we're doing about some challenges. So we are, in addition to the GIPRA, we are collecting a lot of similar data similar to what you are. So knowledge questions, data about attitudes and beliefs, confidence, readiness, and clinical behaviors, as well as some utilization questions. And as a side note, my colleague John McAteer is also on the call with me here and can chime in as well. So we're looking at that data. We're dealing with some lower response rates, especially a number of incomplete responses. So people would start but then finish partway through, because as you know, some of the measures, some are lengthier than others. So we decided to do a few to take on a few strategies to deal with that. One is we're doing some more intensive follow-up. We're having one of our staff reach out to individuals instead of doing, only blast email reminders. Right. And that's helpful. We've also started giving out gift cards for the GIPRA and postcard surveys. So for the GIPRA baseline, we deliver that survey in person, and that's usually a 100% response rate.
Yeah.
With the GIPRA follow-up, we offer a drawing for a gift card, so people who submit it can be entered in and get a chance to get a gift card. And then for the postcard survey, anybody who submits it receives that incentive. So we have seen preliminary success with those measures. And now we're really in a place of what to do about data analysis. The presenter shared a lot of great slides about where what you've been able to do with your data, and so we're sort of trying to decide right now what are the best tools to help us draw appropriate correlations.
Okay, great. Thank you.
Yeah, sure.
Do others have comments? Any response to the discussion topics that are on the screen? Anybody want to share your own experiences?
Aaron, I have one I can share that I see in the chat here. Attending us post-graduation has been an issue. They have addresses and emails for the students, but in a year they seem to change that quickly, and that can cause some trouble keeping in touch. They do use an online survey. The person is asking if has anybody tried social media postings? And Cynthia, I'll unmute you if you want to join in the discussion. Either way.
Yeah, we have never tried social media discussions or posts to try to locate people, but I definitely understand how tracking them for up to a year can be a challenge, and it's certainly something that we've had a challenge with as well, and probably could vary by the types of students that you're training. So, for example, with a resident who graduates and moves into their first practice, they're probably going to be there for a year or more. With an advanced practice nursing student, you just never know. Nursing is really renowned for having high turnover rates, so they could potentially move from one site to another within just a period of months. Yeah, so it certainly is challenging to try to follow people for up to 1 year. If you were training medical students, we actually haven't done any post-graduation follow-up with our medical students because we're training we started with first-year medical students, and then when they moved into their second year, we gave them some additional training. And so since this is a 3-year training grant, that group will just be going into their 4th year of medical school when the grant ends. So post-graduation follow-up is really sort of a moot point with them. But if you were training medical students later in their medical student careers, I could see how it would be difficult to track them as well. Some of them would go into a multi-year residency, but some of them may do an intern year in one location and then move into a specialty residency in another, so you may lose them in that way. But I don't know if others on the call have tried social media, but we have not.
And Aaron, you all seem to be able to track your students' work in their preceptorship and their internship and their clinical on-site training pretty well. Is a lot of that about relationships with those preceptors, or what are some of the factors there?
Yeah, it is. We do a lot of on-site visits to the various clinics to establish relationships there, and it's really critical to find a champion in each clinic that will make sure that the residents or the nursing students or whoever happens to be in the clinic is that SBIRT stays on their radar, and that they realize that there's somebody there that is in support of SBIRT and making sure that SBIRT happens. And the rates vary from site to site, and it really is directly related to the extent to which you have a champion in that site. You know, you can just tell from one site to the next which ones are going to do well and which ones are going to struggle, just based on the level of interest that you have from the preceptors there.
Thanks. I have another question here. I'm going to try to connect her. Tracy, are you there?
Can you hear me? Hi, can you hear me?
Yes, go ahead.
We can.
Oh, okay, great. Yeah, I couldn't get my question earlier, or my comment about the challenges earlier fast enough, or figure out how to raise my hand. But I was thinking, this ties into talking about what's happening in the field with field instructors and preceptors and educators, determining how comfortable, how proficient they feel in the content to be able to teach, train, and supervise others. And I was just, curious how you've approached that, because sometimes folks feel uncomfortable about having their performance assessed, particularly if they are faculty or in some sort of role where they may be expected to already know this information. That was my first question, and then I have a second one, but wanted to get your...
Sure, yeah, let me address that one first. So what we're doing in this particular project is we are doing what we call regional trainings, because our preceptors can theoretically be scattered all over the state. And so what we'll do is we will set up regional trainings in different areas of the state, offer continuing education credits for those who attend, and then push the information about that regional training out through our Office of Continuing Education to the physicians that are in that area, and just hope that our preceptors who are in that area will show up for that training. But yeah, the training preceptors and having them proficient enough to provide feedback to the students that are coming to work with them is a huge challenge, and probably not one that we've addressed that well, but that's what we're trying to do, is to address it through the regional trainings and really going to them rather than expecting them to come to us.
Thank you for sharing that. It makes me feel a little bit better that others are having that same challenge, and we're thinking of sort of going where those groups of people would naturally convene, and instead of creating an event like, what is it, APNA, is it NAPNAP, where is it that they're going that we might be able to get them where they are. So that's another strategy we're thinking about. My second question was, I thought it was really interesting about the different levels of exposure, 2 hour, 3 hour, 5 hour. And, you know, I hear this question a lot is, well, how much do students really need? And is it different for different disciplines? And I don't know that we know that, but I thought it was really interesting because it's one of the first times I've actually seen data presented on it, which is, thank you for doing that. And we're sitting on a lot of data. We can look at that, and it was interesting to see how you presented it, so that was very, very helpful for us. We also have different levels of intensity, so not only do we know how much on screening, brief intervention, motivational interviewing, and RT content was delivered and how much exposure to online education was they were exposed to, but we also have different tiers. So there's like a group of SBIRT ambassadors, for lack of a better word, who get a different level of intensity, and not only do they get training, but they may be doing training of others, so almost like a TOT model, and we're collecting similar data like what you presented across these groups and looking at evaluating, is there a difference? So is it 5 hours is what they need to be a master at this, or is it 20? We don't know, but that was really helpful to see that.
Yeah, well, thanks. Now, we were interested in the same topic, and I've heard other people ask the same question, and it's good to hear that there are other programs that are we essentially have to adapt what our different programs will give us. So, you know, with some programs, all they'll give us is 2 hours to do our training, whereas others have more availability in the curriculum or like to stretch it across the curriculum in several different courses, and so they end up getting more. And we've just found that we have to be flexible in that way. And I certainly don't think that we've answered the question as how much is enough by doing that analysis, but that was one approach to at least try to see if there was a difference based on number of hours.
Thank you.
We're about to go a little over on time, so I wanted to review some closing logistical items, and then we'll see if we can take one more question after that. But so please complete the evaluation. Send the link through the chat, and you can see it there on the slide. And if you're interested in CEH certificate for participating today, we need you to complete the evaluation and then just email me in follow-up to let me know you're requesting a certificate, and we'll get back to you. I also want to share the slides, and I'll put those up momentarily, and then we'll finish up for today.
I also have, I think Brian's going to share this as well. I put together a document that shows our publications over the past 5 or 6 years based on the SBIRT evaluation data that we've been collecting. So there's a handful of full-length articles and about a dozen published abstracts that Brian is putting up there as well. So if you're interested in looking at more of these results or more details on these results, you can download those articles or just send me an email and I can provide you with a full text PDF of those articles if you're interested in them.
Great, thank you. So just to close out, we will post